Hi, good morning, everyone. My beloved colleagues for AKT session here today. Just to help me, anyone, please, can you respond? Can you hear me, doctor? Is my voice
Yes, we can.
okay?
Yes.
Okay, thank you. And the screen is visible, doctor? The screen, can you see the
Yes.
screen?
Yes, it is.
Okay, thank you very much. So, first of all, gratitude to all of you as you are in time in the session, and this is definitely encouraging for us. We are taking few days time just to make our presentation more perfect, not to be very hurried. In the last sessions, a big enthusiasm over there before. And today, now the session will be on the picture recall, pictorials, including ECG, X-ray, fundoscopy, and some clinical pictures as well. So far, we are able to collect from you. Anyway, after pictorial session, if you have to say something, another picture, we will collect from you later on. And if possible, we will invite you for the another session if needed. But today, until we have in our store, we like to demonstrate you today. So as before, I hope that all of you will be benefited and be connected and be interactive. And the session always designed in such manner. Don't think it is very one-way discussion. As much as you will interact, definitely you will learn more, no doubt. Yeah, doctor, I got one request. Dr. BJK. Yeah, I will give you information. I hope very good information to you about this. Until I am talking, be connected with me. Yeah, doctor. So first of all, we are going to start with the picture first one. Please have a look. The first one, that is the baby's picture. Can you see the picture until it is visible in the screen? Can you understand the picture? Please, someone to respond, please. Can you understand the picture?
Not much.
If I want, I can make a bigger one. But at that time, how much it is? Let's see.
Much better now.
I think better now. Yeah, thank you. So let's see now. Child with rash around the face and others. I don't know how much further information included here or not, but up to these informations as text and the appearance of rash is enough to diagnose. But definitely the baby might have some other symptoms which might not be included in the question text. But the picture that much clear, you know the diagnosis. But the question is treatment. What will be the treatment, doctor? Can anyone say?
Conservative management?
For example, option was, let me show. So far we collected maybe that one. PC means actually paracetamol. Anyway, paracetamol, acyclovir, there might be some other medication. So if these are two options here, this challenging option, what could be the answer?
Paracetamol.
Why not acyclovir?
This is chickenpox, right?
Right, why you asking me? You can ask your colleague. Let others say,
Okay.
what is this? Who can say the
Yeah,
answer?
I think chickenpox too.
Chickenpox, right? So in the
Yes.
chickenpox, antiviral drug doesn't have any role because it is very, very self-limiting. But thing is that when you are preparing, you have to know some other spectrum of a picture. Picture question will not be too much, but your thought process will be more expanded. Is there any situation when a cyclobid be given in the chickenpox? Who can say?
Pregnant lady came with chickenpox within 72 hours.
Will you give
Fresh.
the vaccine, doctor?
If she
Sorry,
is more than 20 weeks
sorry.
pregnancy,
I'm
yes,
sorry.
I
I'm not
will.
asking vaccine. I'm asking the cyclopid. Yeah, pregnant lady.
More than 20.
The cyclopid you can think, but would actually indicate it. Immunoglobulin. Chicken varicella immunoglobulin. That we discussed before though. But remember, should we give vaccine in pregnancy or not? This is another question, though it is not related here. The vaccine, whenever any live vaccine, we need to avoid in the pregnancy. So this is the chicken pox in the baby, and another picture to contrast. Have anyone have experience to compare with such picture? Maybe in the younger patient also it appear as such. If you make it the picture more enlarged, I'm just enlarging the picture for a better understanding. I like to show something here. If you closely see that, you can see that in the center of the lesion, there is an umbilication. Do you understand umbilication?
Yes.
If you understand, symptom not given much, only rash. It may not be chicken pox. Chicken pox will be itchy, right? The baby have fever, many other symptoms. But another baby, similar lesions, no other symptom, only such papular appearance, but there is umbilication. What could be a near differential diagnosis? Any clue? Any clue? Mother is patient of HIV. Now, what will be the baby? I'm not telling exactly this picture, but near about this picture with central umbilication. This is also viral disease, not chicken pox. Can anyone say?
Molluscum, something like that.
Molluscum contagiosum.
Yep.
Molluscum
Molluscum,
contagiosum.
contagiosum
Molluscum
molluscum.
contagiosum. Right. Okay. Thanking you. The second picture, have a look. I will make the smaller to show you the answer later. Just look at the picture here, and then I'm making it smaller for better understanding. To show the answer. Sudden chest pain, blood pressure 90/70. What happened wrong to the patient here? It was a diagnostic, possibly diagnostic case. I'm just trying again to show you the big one picture, making it bigger as much as possible. Can you see now in a bigger size? What else? 90/70. Patient is in emergency room. What was there really?
There's widening of the mediastinum.
Widening of the mediastinum, sudden chest pain, blood pressure low. So say some causes of widening of the mediastinum from there. Which disease caused the sudden chest pain?
Aortic dissection.
Aortic dissection. This is your answer. Any other colleague wants to say anything?
Yeah, widening mediastinum is aortic dissection. Retrosternal pain at the back, and chest pain radiating to the back.
I have given 3
The
options.
pericarditis.
Pericarditis will not be that appearance in the chest.
Sir, it is pulmonary embolism.
For that option, we have given a pulmonary embolism. But pulmonary embolism will be, this is infarction of the lung. So infarction will be in the lung tissue, like triangular, wedge-shaped. This is one common appearance. Another, chest X-ray may not be visible anything. There might be after the damage, then might be, if surface damage is there, little pleural effusion. Okay, seems to be normal also in the pulmonary embolism. Only symptom is important. So the mediastinum is widened, it will not be pulmonary embolism. Okay.
Yes.
It could be Not only aortic aneurysm, remember, specifically this is aortic dissection. Otherwise,
yani
patient would not
rupture,
have
huh?
chest pain. Yeah, rupture. Rupture, or you can say minimum dissection. Okay, without dissection, there will not be pain. And why this diagnosis is important as a GP, as a primary physician?
Because it prompts urgent referral.
No, urgent referral, if severe chest pain, it is myocardial infarction, you will refer, aortic dissection also, you will refer, rather to say not by GP, as you refer, when other doctor will receive. What dangerous disease will confuse here by looking at the ECG? Though there is no question of ECG in your exam before. In the ECG, there will be ST elevation.
Yeah.
Okay. If ST elevation is there, the doctor will think that this is myocardial infarction. If it is myocardial infarction, which is a common treatment, thrombolytic therapy, right?
Yeah, PCI.
Thrombolytic therapy. If you give thrombolytic therapy to the aortic dissection patient now, what will happen?
He will die.
Hopefully, patient will die. Patient will die. So, these diagnosis is very, very important. Okay. Sometimes you may try to give aspirin in the chamber. Not I'm telling the coronary care unit management. Right? If we think this is myocardial infarction, what is your initial treatment? Aspirin, isn't it?
Aspirin.
Aspirin, oxygen, morphine,
Doable.
whatever. Okay, oxygen, morphine will create no problem, but aspirin will increase more bleeding there. Again, it will be dangerous also. So, not only for the CCU doctor, as a GP also, we have to be aware. For that, Royal College selected such question with the picture. Thank you. Now the next one. Young patient with back pain, red eye, next investigation. What could it be?
Ankylosing spondylitis.
Yeah.
Question is what next
Spondylitis.
investigation?
If it's ankylosing spondylitis, we'll go. Oh yeah, B27.
If you are confident in
B27.
the X-ray, you can design the answer also. Well, it is not HLA. So what was the answer from here?
From the spine, you're going to see bamboo-shaped.
No, doctor, option
Oh, yeah.
given already. One, CT scan. CT means CT scan. Another is the HLA-B27.
Yes, that's the
Major
answer. HLA-B27.
Major histocompatibility complex type 2.
Yeah.
From there, HLA-B27. Another one, AKPA. What is the meaning of AKPA? Who can say? AKPA. Or another name is NTCCP. NTCCP. Doctor, you must
No
have the
idea.
idea. It is nowadays common test. Anti-citrulinated peptide, carbohydrated peptide maybe, CCP.
Is it for rheumatoid arthritis though?
Citrulinated peptide. Yes?
Is it for rheumatoid arthritis though?
Yes, it is for the rheumatoid arthritis. It is rheumatoid arthritis. So here answer will be HLA-B27. There, what is the picture telling? What is the finding in the X-ray?
Sorry, excuse me, doctor. What is the aqua? What's the full meaning of aqua?
Anti-citrulinated peptide antibody. Citrulinated peptide antibody. If you go through rheumatoid arthritis, you will get it there. And nowadays, this is becoming very common. Before we know about the rheumatoid factor investigation, but for GP also you must know now. We discussed before. Now AKT exam have attained its high profile status. So nowadays you have to be more serious regarding the diseases. For that, those who are using our module, you can see when we discuss about the joint disease, we have given many slides there. Seems to be a very advanced stage, but this is our observation and the current trending also in the exam. So you must read it. But here I am asking in the picture, what findings you are getting? Where is the findings? Please, Dr. Salman.
Sacroiliitis.
Sacroiliitis, very right. Bilateral sacroiliitis. Up to this enough for the discussion. Now the next, tongue with soreness. Tongue with soreness. Other colleague, please. Another thing. Today a little less than before. You can invite your friends, doctor. This picture is very important session. In the meantime, you can send message to your colleagues to join quickly. Everybody has access, right? Help each other. We cannot repeat the class, doctor, this picture. Sorry. You try to help others. Tongue with soreness. What could be the diagnosis? Anyone?
That's a difficult question.
What?
This is a difficult question because many things can cause
Look
tongue
at the
soreness.
appearance. No. Look at the picture. You have to match with the picture. Main thing is the picture. These are some simple tips. Other colleague. Candida. Candida infection. You look at this area. White spots are there, surrounded by redness, and soreness means painful. Really painful. If I want to add some other history, it actually comes and go.
This looks like a geographic tongue.
No. Just look at this picture. Small lesions are there.
Inflammatory bowel disease.
Ulcer?
I'm not
Aphthous
asking
ulcer.
aphthous ulcer.
Yeah.
Aphthous ulcer. Aphthous ulcer.
Ophthalmos ulcer. True.
Just
True.
who said inflammatory bowel disease? Please be connected. You are very nice to answer. But your answer is not correct here. Who?
Me.
Dr. Arwa.
Yes.
Your understanding is very nice. I appreciate. So if you think that this patient might have inflammatory bowel disease, actually we have to think as a GP, not only aphthous ulcer, remember. If I treat only aphthous ulcer, treatment will not be enough. We have to exclude whether there is any inflammatory bowel disease. So what question you will ask? Dr. Arwa, why you become silent?
Yeah. I'm with you, doctor. Yes.
Please
So,
don't be silent. What question you will ask?
any change in the bowel habits?
How to ask to your
Specifically,
patient? More simply, do you have any bowel problem?
yeah, and specifically blood in
Bleeding
the
per
stool.
rectum.
Yes, could be bleeding per
Yeah.
rectum, tummy pain, bleeding per rectum, or bowel problem. Then we
Yeah.
can correlate. It may be part, especially which of the inflammatory bowel disease, Crohn's disease or ulcerative colitis?
Ulcerative colitis.
Sure. Other colleagues are
Yeah.
silent. That means all of you agree.
No, Crohn's disease. Crohn's, not ulcerative.
So
Yes,
Crohn's
Crohn's disease
can
from
affect
mouth to
from mouth
anus.
to anus.
Mouth to anus, not ulcerative
Mm.
colitis. Ulcerative colitis confined in the colon.
Yes.
I can remember in the last class we discussed. I can remember.
Mm.
Yes. So this is the aphthous ulcer. What is the treatment of this?
Steroid gel.
Yes, steroid gel is enough. Oral preparation. It is called oral preparation or oral paste. So differential could possibly might be given before, lichen planus, carcinoma, aphthous ulcer, like that. I don't know as much as other. Those who appeared last exam, you can add if any more. But this is very common, doctor. As a GP, very marvelous question, aphthous ulcer.
Doctor, there was an option of mucocele as well.
Mucosal?
Mucocele.
Mucocele. Might be. But mucocele isn't actually cystic-like area, not that much. But the better option could be like that. Carcinoma, aphthous ulcer, and the lichen planus. Anyway, no worry. Chest X-ray, another one. Should I increase it or can you understand? Increase in the size, zoom. Please help me. Can you see now better? Doctor?
Yes.
Please look at what is the diagnosis. Very fantastic picture.
Right upper lobe pneumonia.
Dr. Nasir is responding after many days. Please, Dr. Nasir, what you are telling?
For me, right upper lobe pneumonia.
Pneumonia, you are telling pneumonia because there is a white lesion in the lung. That is the opacity. Any other opinion from else? But Dr. Nasir, don't be silent. Be connected. I have to ask
I will
something
try
more.
as much as I can,
No
but
problem.
actually
But
I am
let
on the
hear.
duty.
Okay,
But
okay. Don't worry. Don't
there
worry.
is a
Pneumothorax, no. There is a black is black. Don't worry. You confined
Okay.
with the white area. That's all. But
Yeah.
you're told this is consolidation or what said? Pneumonia.
Yeah.
Other
Lobar
colleague.
pneumonia.
Okay.
Effusion.
I am asking the different diagnosis. Okay. One said effusion. Another colleague.
Yeah.
No one telling anything. Doctor, I'm sorry. Every day we are looking X-ray, but we have to be very confident. If you do mistake, no problem today. We are learning today. Everybody should give the answer. It's very fantastic classic X-ray.
Pneumothorax.
Dr. Nasir, if possible, be connected. You tell me why you told this is pneumonia. Rather, if you say pneumonia, I like to say this is consolidation, preferably as a radiologic diagnosis. So if it is consolidation, you see trachea central, white lesion. There are, in the white area, there are some air bronchogram. If you minutely see, you see the black areas inside the white area. This is called air bronchogram. And as there is air bronchogram, for that, we listen in the auscultation bronchial breath sound. Can you remember? Bronchial breath sound. It is due to patent bronchial tree in the lesion. But it could be collapse. Anyone say, why not this is collapse?
Because trachea is not shifted towards the opposite.
Fantastic. And there will not be air bronchogram in the collapse.
Yes.
But in the consolidation also, you may not see air bronchogram. It is technical problem for the X-ray film. Another thing, someone said this is pleural effusion. Doctor, who said pleural effusion? Can you tell me, please? Just for learning, don't worry.
Yeah.
Dr.
Effusion
Arwa.
because there is a demarcated line, like the line is very demarcated. So the effusion is gonna.
Effusion is the water.
True.
Muya, doctora, muya, right?
Yes.
Muya. So this
Yes,
muya
water
will be muya will be below, doctor, not above.
Moya.
Water will be below, not above.
Mm.
And air will be above. There are some simple tricks we have to remember. Pneumothorax, right? Initially will be visible in the upper part. Water immediately will be visible in the lower part of the chest because the chest X-ray done in a standing position, erect position. But if patient is lying, effusion X-ray will be different. Effusion will be different if you are lying. If the X-ray done is a PA view in the portable X-ray, okay. So I am requesting all of you to make you clear, confident. You can see the X-ray discussion. I don't know it's available in the YouTube or not, but available in our module, no doubt. Those who are using, I hope you must know it, doctor. Look at this X-ray. Anyway, so the question was maybe diagnostic question. Let me see. Don't concentrate the next X-ray, doctor. Be with this first, then we will go there. Lobar pneumonia. That was the lobar. Why lobar?
Mucocerebral upper lobe.
Yes, because the fissure. What is the line? This is the middle
Horizontal.
transverse fissure, horizontal fissure. Anyway, doctor, I am controlling my desire to tell more about the X-ray because time will not be there. Some basic thing we must know about the chest X-ray. These are common. Now the abdominal pain and these X-ray abdomen. What could be the diagnosis? Maybe diagnosis, that question. Small bowel obstruction. Sorry, I have shown the, you are not responding, doctor. Sorry for that. I just opened the answer. This is small bowel obstruction. My question is, what are the features here? This is small bowel obstruction.
Dilated loops filled with gas shadows.
Dilated loop you can find in the large bowel also. But what is the characteristic feature in favor of a small bowel, not in favor of large bowel?
Prostration.
Hostra is the
Penetration.
fenestration. No. Hostra is the features of large bowel. Colonic feature. Can
Is
anyone
it something
say
called thumb printing or fingerprinting?
fingerprinting? Also no. Fingerprinting different thing.
Different thing. Yeah. That's thumb printing.
I'm just moving my cursor. Look at, there are some whitish area. It is actually mucosal fold here. From the margin, this margin to this margin, opposite margin, continuous.
Colonis regionalis or something like that. I know.
Yeah, you're trying your best to reach the near.
Yes, colonis regionalis, something like that. I can't remember.
Valvuli conniventis.
Valvuli conniventis.
Yeah.
Valvuli conniventis.
Yes.
And the nature of the valvuli conniventis is from through and through, from this margin to this margin, whole diameter.
Margin, yeah.
But the
Yes.
hostration will not be whole diameter. Okay.
Yes.
And usually,
Sir, can you please repeat?
valvuli conniventis.
Okay.
Conniventis. You will write by spelling, maybe wrong, you can check later. Name just valvuli conniventis. This is characteristic feature of small bowel, especially the jejunal area. Small bowel.
Sir, can you please put your cursor on valvuli conniventis?
Okay, I am annotating by the pen rather.
Yes.
Just
The
one
red
by
one
one.
accent. Yes, sir.
You see this line here. Similar, there are many other line parallel. You see.
Yes.
Everywhere. This one.
Which one?
Minorly
The
visible.
white one?
White one. For your better understanding, I am again enlarging a bigger size as much as possible.
Yes, better.
Sorry, doctor. Yeah. Try your best now as much as possible. These are the lines. A bigger, right? From this wall margin to this wall margin in each lobe. Like comb, Dr. Comb, you can see comb. The teeth of the comb. Straight line, parallel. These are the mucosal fold. Okay. Small bowel obstruction. So your learning point will be here. What are the radiologic difference between a small bowel obstruction and large bowel obstruction? Because you have to face another question, not like this one in the coming exam. This is the learning point here. Now come to the ECG. Patient was vomiting, have diarrhea, and ECG was done. This is like this. Is visible, doctor?
No.
Is visible?
Yes.
Patient done, and someone very intelligent physician has done ECG for diarrhea patient, not chest pain, vomiting diarrhea, and it is found as such. What was the diagnosis? There are some U wave already they mentioned, right?
Yes, U wave.
Hypokalemia.
ST depression, hypokalemia. So can it match with the clinical feature with the diarrhea vomiting?
Yes.
What was the option? Hypo, hyper, anterior myocardial infarction. So there was very dangerous differential given to you. So this was a hypokalemia. So what is the learning point? In the ECG as a whole, common ECG you need to know. And I can recall just last few days before the previous AKT exam, we have taken one ECG classes. That was very important and common. And somebody commented that there was a question from there. I don't know which question it was in the last time. in the last time. So you have to see also ECG. We have 4 ECG lectures in the YouTube open for everyone till now. You may get it, may not get it. If you don't get, you can write. We will give again in the WhatsApp group also, especially hypokalemia, hyperkalemia. These are now new choice from the Royal College.
Sir, can you please tell the other sign and symptom of the hypokalemia?
Hypokalemia, see, this is the outcome of the hypokalemia, is a cardiac arrhythmia, muscle weakness. This is a separate thing. But the diarrhea, vomiting is not the outcome. This is not the features of hypokalemia. This is rather cause of the hypokalemia. Fluid loss and electrolyte loss. Okay. So after math, this hypokalemia patient will have the arrhythmia. ECG will be changed. Okay. Thanking you. Now the fundoscopy. Fundoscopy. This is the picture. These are the options. 1, 2, 3. 3 options given here. Old age female complaining of floaters. Patient have diabetes and hypertension. Floater means patient seeing some bubble-like picture, black spot or watery spots coming and going, moving. And patient may have the other vision problem also here, especially the central vision. You know the macula inside central. So patient may have central vision problem. We have a very common case though in the OSCE practice session of these. Anyway, in the AKT, what could be the diagnosis here? Patient diabetic and hypertensive as well. But appearance is challenging. Is it diabetic? Is it hypertensive or age-related macular degeneration? Now, this is all a retinopathy, doctor. Any problem in the retina is the retinopathy. So you are thinking diabetic retinopathy?
I would choose the diabetic hypertensive silver wiring.
Here, doctors.
Let me say diabetic retinopathy will be dots, blot, microaneurysm, hard exudate, autumnal appearance, many other things. What you are looking there around the macula seems to be white. No. It is called drusen in the center.
Yes.
So if it is the drusen, what could be the diagnosis? There are no other changes in the retina. There is no dot and blot hemorrhage. There is no silver wearing. There is no arteriovenous nicking for the hypertension. So it is age-related macular degeneration.
Yes.
Next one. Patient again, diabetic hypertension. What you are looking for?
Sorry, I have one question.
One question of the previous one, please.
I have one question, please. How do you identify silver wiring?
Sorry, I cannot show you. This is another thing, another discussion in the fundoscopy discussion, doctor. Silver wearing as actually this is the picture of your exam AKT. So we are not discussing the detail of the retina, but for your understanding, as you said, this is the arterioles, retinal arterioles. In the arterioles, there are white line. Along the arteriole, there is a white line. Now a little idea, doctor.
Okay.
Okay. It will be the silver wearing. There are some copper. There are many other words. Silver wearing, copper wearing. You can see. You can see the hypertensive retinopathy. You will understand.
Okay.
Understand. And I think we have one discussion in the YouTube of the retinal diseases. There is a link. I will show you at the later part of the discussion today. There are some links. I will check if the fundoscopy links are possibly there to see a little detail about the fundoscopy. So no worry, you will hopefully you will learn from there. Now the second one, retina is as such, patient is diabetic and hypertensive. Patient complaining vision problem.
Retinal arteries. Occlusion.
Arterial occlusion. Why not venous occlusion?
As this picture.
Someone please, if you want to talk, doctor, just keep your hand raising. Otherwise, if together you are talking, we cannot understand. Hand raising in the Zoom. Who want to talk, you just keep your hand raising. I think all of you know how to raise the hand in the session. Just keep your hand raising. Those who are interested to talk. I will call one by one, no problem. So I am asking now the why not this is venous. There may be venous blood clot also. So nobody hand raising. Sorry. Dr. Ibemo. Doctor, I find your mic is on. Oh, sad. Sorry, don't you understand what I mean? Just raise your hand. I will call, identify. Hand raising not possible, doctor? I think it is possible. Sorry, why silence? Dr. Amira or any? Yeah, Dr. Nasir, thank you. You understand now. You can respond now, Dr. Nasir. What you are looking there? You are
Sorry, I'm not
you don't
good in
know.
the
Okay, keep your
Fundoscopy.
hand raising. Hand raising. No problem. Dr. Javed.
Yes, I think it's cherry red spot because of retinal ischemia.
This is cherry red spot, okay, in the macula.
Yes.
And overall appearance of the fundus is red or other color?
It's pale color.
Pale color. Normal
Ischemia.
retina will not be like this pale, whitish retina. Another word is milky retina, milky.
Yes,
Milky retina.
because of ischemia, maybe ischemic heart disease, ischemia because of
This
ischemia.
is ischemia. This is ischemia. If the venous retina will be there, that means the venous occlusion, there will be bleeding. Another word, a stormy sunset appearance. Many other words are there. So again, you need to go through the detail of fundoscopy, doctor. Fundoscopy. So this is the arterial one. So diabetes, hypertension are the background. More likely, this is central retinal artery occlusion. Crow. There are so many other words. Brow, branch retinal artery occlusion. Another one is CRV, central retinal vein occlusion. CRV occlusion. There are 3-4 words like that. It is very common and familiar word. I hope you will learn from the fundoscopy discussion. Better if you learn tonight, if possible, those who have the time. Okay, the next one, another fundoscopy, a little, what I say, customized picture for your understanding. Old age, patient have the blurred vision. So when you focus by the fundoscope, appearance is as such. You look at the lens area, pupil, what is your observation? This is the focus. White area is nothing. It is artifact by the light source. It is nothing. White spot is nothing. Other things are there. Again, old age. Is visible, doctor, or should I make bigger? Sorry, doctor, nobody raised the hand. I'm sorry if I didn't have any intention to stop you talking, doctor. Please try to talk. If you cannot raise the hand, you open the mic also. No worry. Just I'm just thinking to avoid the overriding talking. Who will say? No idea. There is a loss of the red reflex. Red reflex is not clear. Rather, there is opacity in the red reflex area. That is the lens area.
Cataract.
Yes, this is the cataract. This is cataract. Yes, doctor, please be connected again. Huh? If you trouble to raise the hand, no problem. No problem. So what is that? In the neck area, what you're looking in the picture, patient have the fever, weakness for the last 4 weeks. Dr. Samia.
Cavula. This is tuberculosis.
Tuberculosis. Ahmed, what Ahmed, sorry. And what is the findings of the sign? The name of the sign here you are looking in the neck. Your overall diagnosis is tuberculosis, but the skin diagnosis appearance here. What is this?
This is scabula, lymph nodes, huh? Lymph nodes.
Yeah, it could be lymph node. when there is discharge through the skin, what is the name of the skin lesion? Dr. Javed, why not you? Sinus formation.
Yes, sinus. Yes.
It is called sinus. So sinus is very diagnostic for tuberculosis. So actually they were asking about the treatment. So it is a tuberculosis, we will give anti-tuberculosis treatment. Okay, the next one. Foot pain. Patient have peptic ulcer disease. This is the appearance, but they are asking about the management. In the management, there are some medication I like to show you now. Now choose your answer.
Colchicine.
Prednisolone.
Somebody will give prednisolone, somebody will colchicine. Nobody diclofenac?
No, the patient has peptic ulcer.
Peptic ulcer also.
So doctor, who has given the prednisolone? Please, can you talk to me? Why you are not giving diclofenac?
So diclofenac is peptic ulcer disease.
Peptic ulcer disease. So steroid safe in the peptic ulcer? Now you got the answer. Steroid also not safe in the peptic ulcer. Already patient have peptic ulcer disease. So diclofenac, steroid we will not give, we will give colchicine. And what is the diagnosis? Picture diagnosis here.
This is gout now.
Gout.
What is the name of gout here in the typical area?
Podagra.
Podagra. Other colleague, my beloved Arab colleague, what will you say? Doctor? Arabian colleagues, podagra, podagra. Doctor, podagra, podagra. Sorry, doctor, you cannot talk. Where is the problem of your system? Like to hear you, podagra. Dr. Javed is on only.
Then the meta
Podagra. Fast metatarsophalangeal joint. And there is a soft tissue swelling also, redness, remember. Right. Where is Dr. Arwa? You were active before.
Dr.
Why you open this mic, Doctor? Why you become
I will.
silent?
No, I will.
Okay, the next picture, young male showing acne vulgaris. He used local benzoyl peroxide. I don't know is the mention the name of the disease or not. There might be tricks that in the face appearance is as such. So diagnosis is not the problem now. Appropriate treatment they are asking after use of this medication. What could be better treatment?
ISO.
Doctor?
Is it clindamycin for acne?
This is acne already mentioned here.
Better to start doxy.
You are thinking oral doxycycline. Oral doxycycline. Why not oral retinol? That means retinoic acid.
Sir, actually, as a GP, we cannot give retinol. That's why.
This is the logic. Very right. Very right. GP usually better not to start vitamin A analog. But you can give doxycycline oral. So initial treatment is local treatment. Benzoyl. This is a benzoyl. Benzoyl peroxide local and the tretinoin local. Then next treatment. Anyway, acne is a common problem there. And this is young female foot with itchy rash mainly around toes, exacerbated during winter, especially in the winter area. Anyone from Abha, Dr. Abha in Saudi Arabia here? Possibly you face this Abha, right? Cold area.
Yes, sir. I visited there in January.
Visited there. Those who are residing, cold area, right, Abha? So what the diagnosis here?
Raynaud's.
These are the options.
The second one, yeah.
Second one, chilblain.
Yeah, yes.
Children. So you answered this children in previous session when I didn't show the picture. Today I am here to show the picture. You are silent. And it happened in the Nepal, in the Himalayan. What are the people there? If any Nepali colleague here, I'm sorry, possibly no. If any Nepali colleague today with us in the South Asians. The people there, especially the female in the Nepal, having this appearance in the foot. What are those named people? Diagnosis is okay, but the people name, ladies are there mainly. In the Nepali, they are Nepalis. What are those? Sherpa. Have you heard? Sherpa.
No.
No Nepali today colleague or any Indian also. You can share. Sherpa. Those who are involved by occupation in the cold area, they may have this thing. And even they may have the frost bite also. Frost bite means actually injury tissue. And eyes, the body inside the tissue also become frozen. Then it will be said as frost bite. Almost irreversible damage will be there. Okay, but chilblain up to this itchy papule red area, you see. Red area. Anyway, elbow pain, patient have duodenal ulcer again. So again, option as such may be diclofenac, colchicine, steroid, other. What will you choose? If this is the pain?
Colchicine.
But the challenge I like to hear to ask you, what is the diagnosis here?
Olecranon bursitis.
Olecranon bursitis, right?
Yes, olecranon bursitis.
The next one, middle picture, enlarging skin lesion. What could be the diagnosis?
Melanoma.
This is melanoma.
Melanoma. Was it the actual question, doctor? Who can say if anyone appeared? Actually,
No,
question was a little different. I'm just showing the picture for reading purpose. There was a possibly question was features of the melanoma 1, 2, 3, 4. What is the exact feature? So what were the options there, doctor?
Why we refer more than asymmetry, more than 4 centimeter.
4 millimeter, 4 centimeter, yes.
Yeah, and asymmetry, I think, or elevated.
It is called A, B, C, D, E feature. A, B, C, D, E. 5 feature. This is a mnemonic. Remember, doctor. A, B, C, D, E feature. So there are in the picture already few features are there. Irregular surface seems to be irregular border. Color also not uniform. Enlarging. So all features are there. Suspect melanoma and then refer. Okay, next one. Patient having this red eye like that. Orbital swelling and the redness. So what could be the diagnosis from here?
Sir, what is the answer of the question 15?
Melanoma, doctor.
No, the question 15.
The question, doctor, not a diagnosis. The question why we will repair this patient.
I understand. I couldn't pick it up. I couldn't pick it up. I just heard from you. Now you said the answer, doctor.
Yes.
Doctor, I think who is talking? You can tell the features. I will give the answer one by one.
Sir, the question number 15.
Yes.
No, I'm asking about the 16. 15 is the colchicine, doctor. Colchicine, because duodenal ulcer is there.
Okay, thank you, sir.
And the 16, say the features, doctor, again.
Why we refer the patient? This is a question.
1, 2, 3 options. Options. Say some option.
Asymmetry.
Okay, then another.
More than 4 diameter, millimeter or centimeter. I see millimeter.
Actually, it is not more than 4. It is a bigger. 4 will not the correct answer for referral.
Yes, this is one option. More than 4.
But answer will be the asymmetry. Asymmetry of the color. Asymmetry of the color. Elevated. These are the these are the answer. Not the 4. 4 is actually puzzling you.
Yes. More than 7.
Or 7 or more than 7. Actually more than 6 so far I remember.
More than 7, I think.
More than 6. Not more than 7. 7 itself a feature of malignancy.
Maybe 7 or more.
Okay. Now come to the eye. Now come to the eye. Orbital swelling, redness, conjunctivitis or cellulitis. Cellulitis means orbital cellulitis, rather to say.
Yes.
Orbital cellulitis. What is the answer?
Orbital cellulitis. Eye emergency.
Orbital cellulitis. Okay, next picture. Young man with acne. Patient use benzoyl peroxide 6 weeks. Oh, already we discussed it, right? Sorry,
yes.
doctor. It's a repetition. It's a repetition. We discussed.
Doxycycline.
Sorry, it is. Just let me to delete it. Hair loss, like that. Hair loss like that. What is the diagnosis?
Alopecia.
Alopecia now.
Alopecia is the hair loss, but diagnosis is what type of alopecia?
Rheumatological.
Tinea capitis, doctor, it was, I think.
It is androgenic alopecia. It is fungal infection. That is the tinea. Is it other thing? Or is it SLE? Many causes of alopecia. But this is very simple. Sudden localized hair loss. Specific area.
Maybe tinea.
Not vitiligo, doctor. This is hair loss. Alopecia areata or traction alopecia they are asking. Or tinea capitis. Many questions are there. Alopecia areata or traction alopecia or tinea capitis. Tinea means I said you the fungal infection. Can anyone say? It can happen in the scalp also, doctor, in the head. Area is area. You understand now what will be the answer? Area. Specific area is there. So answer is alopecia areata.
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 Yes.
When it
Please, who is talking loudly, please? Dr. Rabia Noor.
Sir, when this line is in scalp, so the answer will be the same?
Yes, answer will be the same. Alopecia means just hair fall. So hair fall in the scalp, hair fall in the beard area, even hair, this fall can happen in the thigh area also, doctor. Thigh. That means the hair area. Sudden localized area, specific localized area, hair is fallen. This is one kind of autoimmune disease. And other feature found in the nail is what? Nail pitting. Nail pitting. It will strengthen your diagnosis. This is alopecia areata. So it is your job, doctor. Read alopecia areata. It is a very common question. Not only picture, even text-based question also. In the elbow, I can remember the last time also there was the similar picture. I have this picture before, but I have given you now another picture, not the same. So elbow rash, what will you give?
Yeah, so this is silver
Local antifungal.
Psoriasis, give local steroid.
Local steroid. Why this is psoriasis? Characteristic feature?
Silver scaly.
Silver color scale.
Yeah.
Sometime you will be confused. This is silver color or not. May not be that much silvery. Sometime atopic dermatitis. Atopic dermatitis also can produce a scale. You are confused. This is silvery or not. But is there any other feature in the lesion characteristic for the psoriasis? Very little feature is there.
On the extensors.
Location is there.
Extensor one. But another characteristic is that you say red area is there. Small. Though it is incidental, it is incidental. This picture actually I didn't get from Royal College. There is no doubt. This is just our personal collection. Incidentally, I find that there is a red area, little irritation is there. Whenever a patient itches there is a bleeding spot, surface bleeding. It is called auspice sign. Auspice sign. Spelling is not easy. You will look by yourself. Auspice sign. There are some other features also, Kobner phenomena. But this is characteristic auspice sign. You remove the scale, then there will be bleeding spots. It is called auspice sign. Okay. Sorry, somebody trying to write in the chat box. Sorry, doctor, I couldn't give attention more. It will be better if you open the mic and talk, doctor. Eh? Thank you. In the chat box, sorry, I cannot concentrate well. Painful leg rashes. Young patient you see. What is the diagnosis?
Erythema nodosum.
Erythema nodosum. That is the EN.
Yes.
What? Tell some diseases where erythema nodosum can happen.
It can pregnancy, sarcoidosis.
Sarcoidosis, yes, sarcoidosis, even tuberculosis, streptococcal infection, common diseases, right?
Disease.
Sarcoidosis. Even without any disease also, a patient may have only erythema nodosum without any associated disease, right? Yeah, doctor, hand swelling, soft hand swelling.
Ganglion cyst.
Yeah.
Ganglion or cancer. There might be other options. Ganglion cancer. So it's a very typical of ganglion. Yeah. So doctor, until I have the picture, I believe that there might be some other picture. This is our collection. And if you have any further picture, doctor, you can share with us in any other day. We can discuss with you. It needs some time also. And these are the links. Fundoscopy, yes. In the YouTube, you will find Dr. Fundoscopy link. You can go through. And the picture related discussion will be there. Clinical pictures, different tricks and tips. These are the ECG. 4 lectures are there. This is the X-ray detail. Today you become confused to answer consolidation, other. I hope you will be confident after viewing these X-ray discussion in the YouTube. There are some other contraception and many classes are there. This is for you. And this is our program to discuss with you, doctor. I will go to the next topic today. After this, don't leave the session. It is just only what I say, all the links will be available. These links will be available in our WhatsApp group. By rotation, we are putting the video there. And again, if you be updated with us, doctor, I am giving in the chat box as before. Those who still didn't join the group, you can join here in this WhatsApp group. Look at the chat box. So we can conclude here, doctor, about the pictorials, and I hope that someone will have more picture. If you have other than we discussed today, we will collect it for future utilization. And next, we are going to the remaining text-based question, what we didn't discuss on the previous class. So should I conclude it or any further question, doctor, about the picture? Can anyone have any question?
No, sir. Thank you.
Okay.
Hello, doctor. Also, there is a picture of scrophula. Tuberculosis is swelling in the neck like that.
Oh, that is the doctor. Why you suddenly become silent, doctor? Suddenly asking question. Please be connected for easy understanding. Okay.
Hello.
Yeah, tuberculosis. This is a sinus. I think we have seen the multiple sinus picture. Someone, possibly Dr. Taisi, right? You shared this with us. Thank you very much, Dr. Taisi. This picture actually we collected separate picture. There is a multiple sinus could be there also in the tuberculosis. Okay. Any further picture? Anyone to see any question? Any further picture? No more. So,
sir,
yes.
Number 12.
Number 12. This is gout, podagra. Podagra.
Thank you, sir.
Okay.